Welcome, everyone. We have Dr. Albert with us, who is an addiction scientist and a machine learning researcher, founder and CEO of DeepCare Labs, and scientific director of, is this SUDx or SUDx?
SUDx.
SUDx. His work focuses on digital health systems and digital twins to improve medical decision making, operational efficiency, and substance use disorder treatment. He received his PhD from University of Wisconsin, Madison, and completed postdoctoral training at NIH. So with that, Albert, it's all yours. By the way, just for fun, we had another talk in another community just before this, and this one was about ads. And someone said, "Can we have models of ourselves consuming ads?" So AI can create ads, AI can consume ads, and we're all just sitting on the sides then. And I was like, yeah, maybe there can be a digital twin that I can train to behave like me, and then I can make money for just consuming ads. But anyhow,
Yeah.
that
Cool.
would love
Yeah.
to hear more.
Yeah. It's becoming, I just saw like another company getting funding that's focused on a similar idea.
Oh
Um,
well.
yeah. Well, thank you. I'm excited to be here today and to talk to y'all. My name is Albert Burgess-Hull. And just to clarify again, I'm the founder and CEO of DeepCare Labs, which is a digital health company focused on the development of precision medicine tools for substance use disorder treatment. And I'm also the scientific director of SUDx, which is a urine toxicology company that specializes again on substance use disorder treatment, but diagnostics and testing. And so today I'll discuss how digital twin frameworks move opioid use disorder treatment away from a one-size-fits-all trial and error approach to treatment decision making to an adaptive precision medicine framework, which allows for data-driven treatment decisions that are optimized for an individual patient. And I just want to note that although digital twins originated in the aerospace engineering field, where they really transformed the field by letting engineers rapidly prototype different designs and simulate failures before launch and takeoff. We can also extend these concepts to substance use disorder treatment as well, to simulate treatment paths and potential clinical outcomes before a patient starts their treatment. And this allows clinicians and staff to act earlier in a safer, data-driven way. And I'll show how our treatment twin system provides a framework to make this a reality. Um, so I want to first start by just defining what a digital twin is. A digital twin is a continuously updated computational representation of a specific entity. And in the healthcare field, this could be a patient, organ, device, or clinic. And this model ingests data in real time and can forecast and simulate what if counterfactual scenarios. In this last part, the ability to test counterfactuals before acting is really the strength of digital twins for healthcare. This counterfactual simulation allows users to evaluate the outcomes of choices without actually risking real-world consequences. So an example of this might be predicting how a change in a patient's medication dose or adding an add-on adjunctive service like counseling or psychiatry might change a patient's risk level or other outcomes in the future. I also just really quickly want to briefly discuss opioid use disorder treatment, since I'm sure many of you might not be familiar with this area of healthcare. Medications for opioid use disorder, and this includes buprenorphine and methadone, are currently the gold standard treatment for opioid use disorder. And when these medications are used consistently, they reduce a patient's cravings, drug use, and risk of overdose and death. However, the issue is that there's still a large amount of treatment response variability. So while many patients improve quickly, a fair amount, as much as 48 to 75% of patients continue using both during treatment and after treatment. And this really underscores the need for a targeted, personalized treatment framework. The issue in addiction care, and this it really pretty much extends to all of healthcare, is that care teams lack predictive tools to identify treatment responders from non-responders early in treatment. And so what this results in is that providers have to take a type of trial and error approach to treatment, where they wait and then they see how a new patient might react to their initial treatment plan. And the issue with this wait and see approach is that weeks and even months can pass before it's obvious that like a patient's initial treatment plan isn't working. And so this leads to delays in reaching optimal care, risks of over and under treatment, and wastes considerable medical resources. And in the addiction field, especially with opioid addiction, this can be deadly because a patient could overdose. So our solution to these problems is what we call the treatment twin. The treatment twin is a real-time digital prognostic framework that ingests both intake and urine toxicology data in real time to predict an individual patient's response to medication for opioid use disorder treatment. The framework flags patients who need more intensive services right at the start of treatment and also identifies patients who can stay on a lighter touch care plan. And so the treatment twin really operationalizes this digital twin idea for opioid use disorder with actionable risk estimates that are generated at each appointment. And so what these lines here are representing are a patient's treatment response trajectory as they progress in treatment. And I'll explain a little bit more about these scores in just a second. So I'm going to just very quickly discuss how we developed the framework. First, to train our models, we used a large amount of urine tox data collected from over 4,400 patients receiving buprenorphine treatment. And to measure a patient's treatment response, which is what those lines represented in that last slide, we used the OUD stability score, which is a risk score that we developed that ranges from 0 to 100 and represents the probability that a patient's next test is both opioid negative and buprenorphine positive. And this means that a patient is both not using opioids and is also taking their medication. So we compute a score each time a patient attends an appointment to obtain a time series of treatment response scores over time. And so next, with these time series, we use unsupervised machine learning methods to identify the optimal number of treatment response groups, as well as the functional form or the shape of these groups. We then fit classification models to predict a new patient's treatment response group using both intake and urine drug test results at each attended appointment. So we found that the best fitting model was a model with 4 distinct subtypes. And each of these represent a subgroup of patients with unique patterns of medication adherence and opioid use throughout treatment. The largest group, which is the group in green, we labeled the consistent response group. And these are patients who display consistently low opioid use levels and high medication adherence throughout treatment. And so just to clarify, like a higher score is better and a lower score is worse. The yellow group, which we labeled the gradual return to use group, showed initial improvements, but gradually returned to opioid use later in treatment. And the group in blue started with higher levels of opioid use and non-adherence at the start of treatment, but improved steadily over treatment. This is a secondary, what might be called secondary treatment response. Finally, the group in red, the consistent non-response group, was the highest risk patients, and these patients demonstrated ongoing opioid use and poor medication adherence throughout their whole time in treatment. And because this group is at a particularly high risk for negative health outcomes, I'm going to share the results of the classification model we fit predicting new patients' membership in this treatment response group during the first few appointments. So using intake questionnaire and urine drug test data, we found that on appointment one, our model predicting a new patient's membership in this non-response group achieved an AUC of 0.90 and an accuracy of 89%, meaning that we're able to predict whether, if a brand new patient comes into treatment, we're able to predict whether they're going to be non-responsive with 89% accuracy. By visit 6, the AUC reached 0.99 and with an overall accuracy of around 97 to 98%. And this really shows that adding additional data as a patient continues in treatment rapidly improves the model's prediction accuracy, and it really highlights the value of a dynamic adaptive learning system. So to examine why these groups differed on their treatment response patterns, we examined group differences using a patient's intake questionnaire data. I'll just focus on a couple of the major findings that we found. First, we found that the consistent responders, so these are the low-risk patients, had the lowest recent opioid use and the highest buprenorphine use at intake. And they were mostly most likely to use prescription opioids as opposed to illicit substances such as heroin and fentanyl. On the other hand, the gradual return to use group started off with the highest level of recent opioid use, as well as the highest depression levels. The gradual treatment response group, on the other hand, began treatment with the highest percentage of patients already on buprenorphine. However, they displayed the highest amount of current and past stimulant use. And then finally, the consistent non-responders, again, the highest risk group, were the least likely to be on medication and most likely to have used opioids the day of their intake. They also had the highest rates of drinking problems as well as suicidality. So altogether, these differences at baseline really help us understand not only why these groups displayed different treatment response trajectories, but also where to focus early support. So to close, I just want to leave you with three main points. First, medication for opioid use disorder is highly effective at the population level, but the large amount of treatment response variability that we see really demands more personalized approaches. The treatment twin framework, which we have developed, can identify high-risk patient subtypes very early in treatment. And we found that even as early as the first and second appointment. And this allows providers and staff to triage and optimize resource assignment to a patient's risk levels. And our current work is exploring the active deployment of this framework in clinical settings. We actually have the predictions from this model on a dashboard that we display to our clinicians that it is actually being used right now as we speak. And we're also exploring counterfactual simulations to predict optimal medication dosage and add-on services. And finally, we're conducting mechanistic studies, including the collection of different biomarkers in a patient's urine and saliva to potentially illuminate underlying mechanisms that may explain a little bit more about why these patients are responding. differently to treatment. Thanks so much for listening to my talk. And if you all want to reach out and ask any questions or send me follow-up questions, here's my email. Thank you.
Thank you so much, Albert. May I request you to please stop sharing your screen
Yeah.
and we'll go into Q&A. Linda, and then Randall, please go ahead.
Hi, thank you. Great talk, Albert. So I
Thanks.
imagine you're also trying to optimize treatment and test whether you can bump poor responders into higher response groups, right?
Yeah, yep. That is the next step and extension of the model. Yep.
Thank you.
Um, maybe I didn't quite catch it. How are you getting the data in? So I know you've got your model and you're iterating on that as you progress, but when you're talking to actual patients during in treatment, how are you getting that data?
Yeah, so we we have a database that connects to our LIS system, which is like it's a laboratory information system that provides somewhat real-time results from the urine toxicology tests that a patient takes every time they come into treatment. So to give a little context, every time a patient comes in to addiction treatment, I guess it depends on the type of substance use disorder treatment. But for opioid use disorder, they take a urine test every time they come in, and there's different types of urine tests that can be like a screening test or a confirmatory test with it, which is done via mass spec. But anyways, this goes to a lab, and then we get it back via this LIS system. It then gets ported to a database, and the model, the system then uses that data to calculate these predictions in real time.
Got it. And how frequently is that data pulled on a per patient basis?
We run the model at least just because these are at least just actionable like at a daily basis, and we run it daily. So if we had a lot of these digital twin systems, it depends on really the forecasting interval. Like if you're trying to forecast or predict at a intraday, even like I mean you could predict at millisecond level depending on or second level depending on the system you're trying to model. But for us it's just daily the frequency.
So sorry, are patients are in taking labs daily? The same patient is in.
So yeah, so the labs come back like 3 days after they take a test. They also take a point of care test, and so that comes like back, the results come back immediately. And so we can use either this point of care results or this more
Sorry,
refined, reliable test that comes
maybe
back
just
three days
to
later.
focus the question, like over the course of a month for a single patient, how many lab result data points will you get?
It depends. So if they're like high risk, it depends on the outpatient clinic or the risk level. So like at least at the clinic that we associate with, like high risk patients might come in weekly. And then our low risk patients come in maybe monthly.
Okay,
So it depends on the risk level of the patient.
thank you. David, I
David,
think you're up next.
yeah.
Sorry, hunting for the mute button.
No
So
worries.
sorry, I'm not from drug discovery or the biology field at all, so forgive the naivete in the question, but
Yes, right.
would you consider this a diagnostic? What is the relative gold standard? And so you said 89 and you got to 95%
Yeah.
accuracy. It- for the 5% you're wrong, what's the impact on their care? And so what's the expectation the FDA or industry has?
Yeah, it's a really good question. I think it falls into, I label it a prognostic tool, because it does really forecast, like, right, the difference between diagnostic is like you're categorizing a condition cross-sectionally at that time, and a prognostic tool is you're trying to forecast the future state of a condition at a later time. And so I think it really falls into both categories, but I think I call it a prognostic tool. But to answer your question, there is no, to be completely like transparent, like there is no a data-driven or even individualized recommendations that are standard of care for opioid use disorder treatment. There's high-level recommendations for like individuals who are pregnant and adolescents, for example, but it really comes down to the provider, the subjective decision making of a provider and their individualized experience, and also their training. So there is no baseline to compare it to, really. So I think that our argument is that it's better than okay, so like to step back, that variability introduces treatment response variability that is a function of provider subjective decision making, in addition to these physiological and environmental factors that might influence treatment response. But yeah, there is no gold standard recommendation. So it's better than nothing, basically.
Do you feel like you have to prove it's better on average than an average group of providers?
Totally. Yeah, we needed to do a head-to-head comparison of across like different what we plan to do is across different training levels, provider training levels, and then like mimicking what other clinical decision making studies have done, like both augmented. So I imagine like non-use of the clinical decision support system, augmented use, and then use of it. Well, actually, just these two conditions. Yes, I do think we need to do a head-to-head comparison.
Thank you, Linda. Sorry, David, are you done or do you
No,
have?
I was saying I'll get back the floor.
Okay. Linda, back to you. And if anyone else has a question, Sherwin, Ali, Nero, welcome to the community. Rahul, please just raise your hand or let me know, and I'll hand the mic to you also. Linda?
Just to add to what Albert said, to David's question, there are regions, whole regions of the United States where only a minority of clinics offer MAT. So, optimizing treatment response with buprenorphine or methadone can only happen if the clinic even offers that. Many clinics, for example, only offer non-evidence-based treatments in contrast to this medication-assisted treatment. But Albert, I wanted to ask, I'm really surprised that using urine toxicology alone, you can, over the weeks of treatment, you can get up to 97% accuracy of whether they're going to relapse. Or were you surprised by that? I would have thought to get to that level, you would need things like CT scans and fMRI and because that's more typical for other diseases.
Yeah, I think it really yeah, it's like when it really differentiates the responders. So like these stable flat trajectories, the responders from the non-responders, it gets it gets more dicey with these like increasing and decreasing trajectories. But yeah, we were very surprised. But we think that like adding in these additional data sources, like you mentioned, we were thinking more biomarker, like inflammatory markers, for example. which appear to have a lot of predictive power for future treatment response, specifically for methadone patients. That's sort of our sort of direction that we're going. But yeah, good points.
Okay, last question for the day, Ali.
Hi.
You're
So,
right.
sorry, coming from a very non-medical background, but I was curious. There was a particular phrasing you used, something like overall effective, but a lot of divergence in the within people. And my understanding is that is a lot of medical medicine. And I was curious to hear where else do you think the systems that you're developing would be really beneficial?
Yeah. So just to clarify, like you were mentioning the decision-making variability within providers and clinicians. Is that where you're?
For other conditions, other conditions
Yeah,
other
yeah,
than
yeah. Yeah, totally. I really, really think that it's just I mean, I don't, yeah, it's applicable and an issue in a lot of other medical domains. There are some fields that are leading this space, precision medicine, precision oncology, right? That they've really started the path towards precision medicine. They tend to focus on genotyping cancer, and they're focusing on a lot of genetic precision frameworks. But I think because we're focusing on time series data and really focusing on trajectories of response, at least the immediate translatability of our framework to other conditions would be chronic health conditions. So pain management, diabetes, maybe heart disease, these conditions where you have um, at least some sort of temporal measurement that allows you to evaluate dynamic changes of some type of condition. But it could be extended to to future prediction of single time points as well. Neurodegenerative diseases is also another field that's really leading the pack in terms of computational modeling of trajectories of response.
Thank you. So things that will most likely kill us.
Yeah.
Thank you so much, Albert. This was my first introduction to the emerging world of medical digital twins. Very exciting. I feel like now we have a big enough community to also create a Slack group. So hopefully that should be coming soon and we can continue some of these conversations there. Thank you, everyone. I'm sorry we're again 2 minutes late. I'll try better next time. Have a great day.
Thanks,
Bye-bye.
everyone.
Thank you.